Good afternoon. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Outside the Box Webinar Series, Media and Publications. My name is Kelly Gibson, and I will be your moderator for this program as well as one of the speakers. All materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. As I said, my name is Kelly Gibson, and I am a program manager with the Patient Safety Authority. I started with the Patient Safety Authority as a patient safety liaison for the South Central region of Pennsylvania. Prior to working at the Patient Safety Authority, I worked in patient safety in an acute care hospital and engaged in patient safety initiatives at the system level. My clinical experience includes critical care, medical, surgical, and PACU. Also joining us today is Michelle Bell, the Director of Outreach and Education with the Patient Safety Authority. Michelle joined the Patient Safety Authority after completing a year-long fellowship with the Institute for Safe Medication Practices. Prior to her role with the Patient Safety Authority, Michelle practiced as an emergency department nurse and filled a variety of roles in shared governance, compliance, patient safety, and quality management. I will now start by going over some of the introductory slides. And if any of you have been on our previous webinars in this Outside the Box webinar series, some of these first few slides will look very familiar. For anybody that is new to this series, I do want to touch base on some of these just because of that there is the potential for new participants. So in 2022, OIG report was released that talked about adverse events that are occurring in healthcare facilities. I think to define adverse events is very important, as there's a lot of different terms that are utilized in relation to patient safety, whether we talk about harmful events, sentinel events, and whatnot. For the purposes of this report, adverse event is harm to a patient as a result of medical care or in a healthcare setting, including failure to provide needed care. And this report identified that roughly one in four hospitalized patients experience harm. 43% of those adverse events are temporary or temporary events were preventable. In 2012, OIG report found that 14% of patient harm events were reported into the internal incident reporting systems. That's a big discrepancy. We're the remaining 86%. And that's what the purpose of our webinar series is about. How do we identify that remaining 86% and how can we get those events into the reporting systems? How did OIG identify these adverse events? Medical record reviews, and as we all know, those are time consuming, they can be very lengthy. The global trigger tool was utilized as well, and that was a systematic screening of records to identify and look at clinical cues that are occurring with patients that are indicative of patient harm. So how do you identify adverse events if you do not have these things readily available or the resources to do that? And/or the communication and optimal resolution, one of the toolkits looked at different ways, and this is what this depiction is. This graphic shows different ways of identifying those events. And that's why we put this webinar series together. As I said, you may have participated on one of the 4 previous webinars. This is the 5th and final, media and publications. So today we're going to look at ways patient safety leaders can use media and publications to identify patient safety events and possible opportunities for improvement occurring throughout the organization. Michelle, I will turn the program over to you.
Awesome. Thank you, Kelly. So media and publications, this is what we're here to talk about today, obviously, as Kelly so eloquently said. So how can we use media and publications to help us find where these events are probably already occurring in our facilities, or even better, find out where the risk exists before they even occur? So here we have a couple things listed. And we've talked about a lot of stuff over the course of this series. You know, we've talked about different tools you can use, or different screenings or chart audits or things, and they all require you to go and look for them. Media and publications is a great way to have them kind of fall into your lap. Instead of, pulling out a record and going through the record trying to find where opportunities were, um, we know that there's a risk. We know that something bad happened. It was in the media. It was published in something. These are things that are probably going to be riskier events or things that are more likely to result in some type of a harm. Of all of the patient safety events that occur, you don't usually see news stories about the near misses. You're going to see the news stories about the things where someone died or experienced a really, really bad outcome. And then this is your opportunity to fix them before you're the one in the news. And I think sometimes we kind of take that for granted. So this first case that I'm going to talk about, there we go, the Dennis Quaid twins. And I bet most of you probably heard about this event at some point. But back in 2007, Dennis Quaid and his wife Kimberly had a set of twins, and they were admitted into the NICU after they were born with a staph infection. During the course of treatment, they received IV antibiotics, and they had hep lock. Um, they were supposed to receive 10 units of insulin per ml into that hep lock, and they were administered by accident 10,000 units per ml of heparin into that hep lock. They experienced bleeding complications. They had to stay in the hospital longer. There was concerns that they could die. And this made big, giant national news. Now, some of you may be looking at this and be thinking like, oh gosh, thank goodness that couldn't happen to me. This could. And interestingly, the Quaid event was in 2007. Back in 2006, 6 babies in Indianapolis experienced the exact same error. They had hep locks. They were supposed to receive 10 units of heparin per ml into their hep lock. They received 10,000 units. The error happened in the same way. The automated dispensing cabinet in the NICU had been stocked incorrectly. And if you look back at what the heparin vials looked like at this time, the 10 unit per ml heparin had a blue label on it. The 10,000 unit per ml heparin had a slightly darker blue label on it. It was put into the ADC. Confirmation bias allowed the nurse to not recognize that this wasn't what it was supposed to be. It was a blue label. It was heparin. The 10 was there. And 3 babies in Indianapolis died the year before. So we have a case in Indianapolis in 2006. We have the case in California in 2007. And there was a very similar error then in 2008 in Corpus Christi, Texas. 17 babies died, or I'm sorry, 17 babies received the inappropriate dose of heparin. 2 of those babies died. So we now have 5 babies who died. We have 24 babies, 23 babies, whatever it is, who received incorrect amounts of heparin and experienced some level of complication, additional healthcare services, monitoring, blood tests, etc., to either prevent harm or make sure there wasn't any other harm, all within a 3-year period. The Corpus Christi event was slightly different. That one was a pharmacy dosing error, not an automated dispensing cabinet stocking error that was at the root of that one, but a very, very similar type of situation. We've also seen events in Pennsylvania. You can look back through things that we've published here at the Patient Safety Authority, things that have been published by other folks. And there are lots of examples of miscalculation of heparin. So if you don't have a NICU, that doesn't mean that you're safe from heparin errors. If you do have a NICU, but you don't stock the 10,000 unit per ml vials, that doesn't mean that you're safe from these errors. These types of events should be triggers for us to stop and look at our processes. And that's exactly what you should do. Those are your strategies for prevention. When things like this come into the news, take a step back. Think about, where are we using heparin in our facility? What are the types of things that we could do to reduce risk? Where are the biggest risk points? So, for example, I had worked with a facility after the Corpus Christi event and looked at all of the places it was a fairly large tertiary care center, all of the places in the facility, like where they had heparin, where was it stocked, where was it stored, what was the formulations, and there was 36 different formulations of heparin available in the hospital. That's a lot of opportunity for error to happen. Um, at the end of all of that evaluation and all of that work that we did to figure out where the risk could be, we went back with a recommendation to get it down to 12. So eliminating almost 2/3 of the formulations. We suggested eliminating the 10,000 per ml vials completely, so that the highest concentration available was the 5,000 unit per ml. You're much less likely to have that confirmation bias with a 5,000 unit per ml vial than you are a 10,000 unit per ml vial, which then makes the next concentration amount, the 1,000 unit per ml vial, only 100 times overdose and not 1,000 times overdose. So you're exponentially decreasing your risk by doing those types of things. And strategies like this, if you need help developing strategies for things like that, you can go ahead and reach out to your patient safety liaison here at the authority. Most of the articles that I'm talking about, when we talk about like ISMP or the patient safety authority articles, there's lists and lists of risk reduction strategies that are available in those to look at what are the things that you can do. So think high leverage, think about fixing the system. Don't rely on the people, and use these media stories as an opportunity to evaluate your processes. I'm going to bring you up a little bit to the more recent history, and talk about the RaDonda Bot case. I think this case, for those of us in patient safety, is near and dear to our hearts. We've probably read a lot about it. If you aren't familiar with it, I'm going to give you a little bit of rundown as to what happened in this particular case. So this was a situation where a patient, Charlene Murphy, was admitted with a headache and field vision loss in her left eye. She was admitted to the neuro ICU. She had an MRI that showed an intraparenchymal hematoma on her brain, and they thought there might be a mass in behind that hematoma. So a couple days after she was admitted, they were getting ready to transfer her to a step-down unit, and they wanted to go to radiology and do a PET scan before that transfer out. Miss Murphy was very anxious about the PET scan. She had claustrophobia. She asked for something to help with that anxiety. So they called her doctor, and he put in an order. He actually put in two orders. The first one was for Versed, 2 milligrams IV, and then it said for PET scan, if first milligram insufficient, can give 1 to 2 additional if needed. And then he entered a clarifying order that said for one-time dose of Versed, 1 milligram IV prior to PET scan. And that the pharmacist verified the order just within a few minutes. Now, as a side note, Versed is not actually even commercially available anymore. As a brand name, it's only available as midazolam. So the radiology tech called the patient's nurse and said, hey, I have this order for the IV Versed. Can you come down and give that to her? And the primary nurse said, like, I'm a little tied up. Could the radiology nurse do it? And she said, the radiology nurse really isn't comfortable with Versed. They have to be monitored, and we really can't do that. So the ICU nurse said, I'll have somebody come down, just, give me a minute. So the tech went ahead and gave the radioactive tracer for the PET scan. And the help all nurse or resource nurse or whatever you want to call it in your facility, they called it a help all nurse at Vanderbilt, RaDonda Bot, was orienting a new nurse. And the ICU nurse said, hey, RaDonda, can you go down and give this Versed to the patient? And she said, I'm on my way to the ED to do a swallowing study, but I will swing by radiology and give it. That's fine. So she went to the automated dispensing cabinet and entered VE into the automated dispensing cabinet. Now, didn't pop anything up. She didn't think too much of it. There was a history of sometimes things taking a little while for the order to be approved by pharmacy and get put into the automated dispensing cabinet. She also didn't notice that she was on the generic default page of search, and not on the brand name search. And so she went in, she overrode, um, entered the VE again into the search field, and picked the first medication that populated, which happened to be vecuronium. Because the override function had been used, there was a little pop-up that came up that said like, hey, this medication needs to have a stat order. And she's like, yep, I have a stat order, and pulled out the vial of vecuronium. Vecuronium comes in a powder, so she saw it was a powder. She said, oh, I need to look at how to reconstitute this, and turned it over and read the reconstitution directions, grabbed the syringes, grabbed a flush, grabbed the saline to reconstitute it, and put it all in a bag that said PET scan, Versed 1 to 2 milligrams, and went down to radiology. In radiology, she found Mrs. Murphy. She reconstituted the medication, and she gave an unknown amount at that time. She thought she had administered 1 ml, which would be 1 milligram of Versed. She put the rest of what she thought was Versed and all of the other stuff in the bag and put it back in her pocket. She went then to the ED. A little while later, the tech in radiology noticed that Mrs. Murphy wasn't breathing, called for a rapid response and then a code, and Redonda responded back to radiology from the ER when that call went out. After the patient was transferred, she went back up to the ICU, the neuro ICU, after the resuscitation. And Redonda said, like, hey, I'd given her the Versed about 30 minutes before that code was called. And she gave that bag containing the empty vial and the syringes to the patient's primary nurse to document the waste. And the primary nurse is the one who then identified the error and what had likely happened. And that was told to the physicians, who then disclosed that to the family. And then a few hours later, Mrs. Murphy began displaying signs of anoxic brain injury, myoclonic jerks and posturing, and a CT of the head at that time showed an increase in swelling. And they suspected that her current status was a result of the medication error and not because of her existing clinical condition prior to that. So, thank goodness this couldn't happen in Pennsylvania, right? This was big, giant national news, and it was all over, like, nursing boards, on all sorts of social media and news articles. And when you look at these types of events that make big news, they're horrible and they're tragic. And our initial gut reaction is like, oh, thank goodness that couldn't happen to me. It could, and we know it can. Back in, oh gosh, 2009, we published an article in the Patient Safety Advisory about neuromuscular blockers and errors that we have seen in Pennsylvania with neuromuscular blockers. So, for those of you who don't have a clinical background, neuromuscular blockers literally block the muscle from being able to move. We do that when we intubate people to keep them from harming themselves. But they have to be intubated and ventilated when you give a neuromuscular blocker, because it doesn't just paralyze your arms and your legs, it paralyzes your diaphragm. So you literally cannot breathe. You have to have some type of mechanical or ventilation happening for the patient because they cannot breathe on their own. So we published a study back in 2009 looking at events that had been reported since we started collecting events in 2004 through 2009. And we found 154 medication event reports that talked about neuromuscular blocker events. Of those 154 events, 57 were wrong drug errors. So about 37%. Of those, there were 5 cases where Versed was described and a neuromuscular blocker was given. So in a 5-year period in Pennsylvania, and actually less than 5 year, no, I think we did do 5 full years. 5 years of drug event in Pennsylvania, we had 5 cases of an order of Versed and a neuromuscular blocker being given. This has happened once a year in Pennsylvania during that 5-year period, basically. It could very easily have been one of our facilities in the news at that time. In 2016, ISMP wrote about neuromuscular blocker events again. That article included an example of an event where midazolam was intended to be given and a neuromuscular blocker was given instead. And there's all sorts of other publications out there you can find about very, very similar events. The risk with neuromuscular blockers is big. So again, what are your strategies for prevention? Is this something that you've looked at? Is this something that you've considered in your facility? How are those medications labeled? Like, I think at Vanderbilt, they had a, warning, paralyzing agent. That might not be the wording that we need to use on a label. Maybe it needs to be like, patient must be ventilated. Maybe it's not having neuromuscular blockers available except for within either an anesthesia cart or a rapid sequence intubation kit. So you have to be looking for them specifically in order to access them, but you can get to them in an emergency when you need to. What's the override process look like? Maybe you don't use neuromuscular blockers at all in your facility, but maybe there's some risks around how you function with your overrides. How are patients oriented? How are patients monitored? Like all of those things, events like this can be a trigger for you to look at those processes and find out where your risks are. In 2014, ISMP started publishing an annual list of their best practices, and it has been neuromuscular blocker management has been on that list since the inception of it, because this is a known risk. And Vanderbilt, if they would have been doing these things and taking that opportunity to identify where opportunities were, this wouldn't have had to happen. So Kelly, I am going to turn it over to you to talk about a couple more events, and I'll be back later in the presentation.
Thank you, Michelle. Infections are an area that I think has come a long way, or infection prevention has come a long way over the past years. So every now and then it seems that there's one that kind of sneaks up that has maybe an unusual kind of presentation. And Mycobacterium, kind of a rare nosocomial infection. And when some of these popped up in a New England hospital back in 2018, one of the physicians involved in the care of these patients kind of said, "Hey, this is a little odd." So with that, I guess the sleuthing and investigation started, and what they found was actually doing some genome sequencing. So looking at the genetic makeup of these organisms, they figured that these infections were all very much from the same source. So they started looking and digging into things, and these were open heart patients. So they looked at ventilators, they looked at the bypass machine as far as the heating and cooling unit. These were common things that would have been maybe sources of infections, and they all kind of came up clean, so to speak. So once they ruled out the obvious sources, they were still doing a lot of research, talking to staff members. What they identified were a common thread with these patients was that they had a prolonged length of stay. So they were all kind of in the hospital on one particular unit, and in talking with one of the staff members, they recalled one of the patients was eating more ice than others or more ice than usual. So from there, they started looking at their ice machines, and what they found was kind of intriguing. They recognized that they had installed a purification, so to speak, system. This system was using a filter that was extremely small, and they did this for basically the benefit of taste and odor. They also had installed a UV disinfection unit with these machines. What that essentially did was stripped any chlorine from the tap water, which allowed the bacteria to grow at low levels. And of course, it was forming a biofilm inside the machine despite proper cleaning and maintenance and what they were supposed to be doing. So this was their source for the infections. There were, I think they identified 4 patients, and 3 had lost their lives as a result of that. And with some of the investigation, what they really talked about are the risk of unintended consequences associated with these system designs. We put something in place that was to help and be beneficial, but one of the negative outcomes was and results was this component with the chlorine. So you think, oh, well, that's not going to happen to us, right? We don't have that type of machine, or we don't use that type of ice machine, whatever. But there were a couple cases, and some of these were occurring in the state of Pennsylvania. And a hospital had some infants in their care that developed Pseudomonas bacterial infections. Of course, this patient population is extremely high risk and fragile. 3 of the babies ultimately died. And again, they started really digging into the data, digging into what was going on, and did DNA testing, traced the bacteria back to equipment that was used to measure donor breast milk. They ended up being citing for not having a written policy to clean this equipment. And what that organization did is switch to single-use equipment to measure and administer the donor breast milk. Another organization found, and the sequence of events, and this is kind of interesting to me because there were some studies that were published as well that kind of made some investigations occur. The non-tuberculosis mycobacterium infections, and this was occurring in open heart patients. And what they found was that the equipment in the operating room, again, a heater cooler unit, devices that were used, could potentially aerosolize bacteria that was within the unit. And although none of the fluids, because it's an external canister, that is where the heating or cooling occurs, that liquid flows in a closed system to blankets with the patient. And although there is no communication between that fluid and the patient, there was opportunity or locations within the equipment where you could have kind of, I'll say, escaped liquid. And if that occurred, the exhaust fan could aerosolize the bacteria into the air. And this resulting investigation, when working with the CDC, it ended up in, when looking at data, the FDA had received between 2010 and 2015, 32 medical device reports of patient infections that were associated with this device. So there was definitely opportunity, and looking into that and trying to see, what can we do to minimize our infection risk. And with that, facilities really started to look at their maintenance, their preventative maintenance, and how they were handling those situations. So what can you do? You might think, well, hey, we don't do open heart, we don't have this kind of ice machine, but it's an opportunity to step back and take a look at your processes. What are the policies that you're finding around, or that you currently have in place related to some of these things? What is your preventive maintenance? What is your cleaning process? Are you following the manufacturer's recommendations related to care and maintenance? We had a facility do a webinar on our behalf several months ago, and that video of the webinar is on our YouTube channel, Avoiding the Clinical Equipment Landmines. So look to that as a resource on possibilities of what you can do in these situations. Be aware of unintended outcomes. Are there things as we're making changes within our organizations? Are there unintended consequences of those policy changes and the processes that we are putting in place? I'm going to move on to a topic that is relatively near and dear to our heart. I think from the Patient Safety Authority standpoint, we have done a lot of work over the years related to prevention of wrong site surgery. And although this case is a little dated back in the early 2000s, I think it's relevant to a lot of the work that we continued to do from our organization. Dana Carvey, everybody probably remembers him, great guy from Saturday Night Live, good comedian, ended up needing cardiac bypass surgery. He had a blocked coronary artery. They had attempted to do angioplasty. It didn't work. He didn't have the results he needed. So he was actually slated and scheduled to go in for open heart. On that morning, he's jovial, he's cracking jokes just prior to surgery. Surgery goes well, everything is fine, the recovery went well. But 2 months later, his symptoms returned. He goes in for a follow-up appointment. It's actually with a different physician. And it's then that he's notified that the initial surgery was done on the incorrect vessel. It was done basically on a healthy vessel, not a blocked artery. So he, at that point, was at risk for having a significant cardiac event and underwent an emergent angioplasty. At that point in time, they said, it's a little too risky to do a second surgery right now. He eventually did have the second open heart surgery and everything went well. What they said in looking back is it was due to some unusual positioning of that cardiac artery. Whatever the reason, and you might think, hey, those aren't going to happen here. I've talked to facilities over the years that are like, hey, we do everything right with the timeouts. Recognize that this is data from Pacers. This is the reports that we receive from you and your facilities. From 2015 to 2019, the state of Pennsylvania averaged 1.42 wrong site surgeries per week. So we might think, oh, these things aren't continuing to happen. Well, guess they still do. They're happening in this state. Who's going to be the next one? Most of these occur in the peri-op setting, but recognize that they occur in other locations as well. We've also, in breaking out interventional radiology, over this same time period, what we found was that 6 to 13 are occurring in interventional radiology on an annual basis. Okay, so they're happening in Pennsylvania. We had that other case with Dana Carvey. That's it, right? No, there still are other cases that have occurred, and sometimes they are pretty significant. Back in 2007, there was a case of an 82-year-old who had a head bleed, just had a CAT scan prior to surgery. The surgeon starts by drilling on the incorrect side of the skull. Till he realizes it, he's able to stop. They repair that site and they do the surgery on the correct side. But as the patient was okay in that case, but imagine from the patient's perspective. There was a case in Minnesota. A patient was to have a nephrectomy for potential malignancy and the wrong kidney ended up being removed. Now, in that case, there's not a lot of detail to look at as far as being able to, what were the contributing factors. There was, I think, a gag order placed on that case. Back in 1995, there was a 52-year-old in Florida who had the wrong leg amputated. As they're doing the dissection for the amputation, they recognize at some point during the surgery that the wrong leg was being done, but at that point they were too far along. They couldn't, do I want to say backtrack, but they had to proceed then with the amputation of the incorrect leg. So again, you might be thinking, hey, this is never going to happen here, right? We do our timeouts, we do them great, we followed all the steps. It's been a couple of years now since I went into a peri-op setting to look at, well, what are you doing for your timeouts? What are you doing as far as the standard to prevent wrong site surgeries? And it's interesting to take a step back and look at what are the quality of the strategies that you're using. Maybe you're all, we're checking off the boxes, but how well are we doing those? Are we verifying that site marking during the timeout? Are we actually looking at it? I just looked at some from our patient safety officer surveys that we do on an annual basis. When I was looking at some of the input for one of the questions was about barriers to this very topic and these strategies to prevent wrong site surgery. And some of the things I saw were lack of participation, inclusion of everybody on the team, um, making a complete stop as opposed to we're doing the rolling timeout. So I think there's still a lot of opportunities to how well we are doing these strategies for preventing wrong site surgery. When it comes to wrong site surgery, we do have tools on our website. You can use them, peruse them and look at all the ones that are available. Recognize that we have some that you can do kind of a gap of your overall program and all those interventions and strategies. You can pull some that are about doing actual observations. Whatever might be beneficial to you, we probably have it. And if not, and if you or aren't sure, contact your representative from the Patient Safety Authority. There's someone that is going to be willing to come talk to you. And like I said, we mentioned observations. It's interesting from an outside perspective to come into a facility and observe what is happening. The other thing is that some of this stuff starts to kind of get the conversation rolling and changing culture. How are we talking about concerns that we have? Because I know years ago I worked with a facility that there was a piece of equipment that was involved in an event. And after the event, then we had surgeons saying, hey, guess what? That piece of equipment is horrible. Oh, that's bad. And suddenly all these stories were surfacing about the quality of the equipment. So having those dialogues and having those conversations before something happens. And I think Shelley had put from that last tool, put the link in the chat box. So if you're wondering where to find that, that'll be on our website with that last link that Shelley posted. Thank you, Shelley. And maybe it's not wrong site surgery. Maybe it's something else that your facility is working on. We have a lot of patient safety topics on our website. These are great resources to start conversations, to start looking at your internal processes. Where do you have opportunity for improvement? And if you can't find what you're looking for, again, reach out to your patient safety liaison. And not that you have to follow the tools that we have, and it's not that they're the end all be all, but recognize that these are helpful in asking questions and having conversations. So we have a root cause analysis form. Again, this can help you if you do have an event, looking at all the components, looking at all the possibilities. Where are there opportunities for improvement? And of course, in the background there, that is the article where I pulled that one slide that listed the 2015-2019 data with wrong site surgery, but you can always look to our journal, Patient Safety. Use these articles for starting points to look at initiatives that you might want to spearhead in your organization. And if nothing else, maybe it's just starting the conversation about the topics that are involved. You can also use our safety alerts. These are things that we have been pushing out to facilities when something comes up that might be highly unusual, high risk, and there's a big risk to the patient. So look to these as far as what can you do? Do you have an opportunity for improvement? This one was our most recent one that we released. This was about methylprednisone. So you're talking an IV steroid, which is typically given in high risk situations, I'll say, and in some cases, and this was they identified a warning for patients with known or suspected hypersensitivity to cow's milk, and there was an allergic reaction to a dosage that was administered. So these are kinds of things that you might want to take a step back and look at your facility and your organization and what's happening. Michelle, I'm going to turn the program over to you.
Thank you, Kelly. So I'm going to talk about some additional sources of information. So we have, things that show up in the national news, things that show up in, your local news, maybe. There's things that we identify and publish in our journal. It's free to subscribe to the journal. It'll be delivered to your email inbox every time it's issued. You can sign up for our safety alerts and get those sent right to you. But there's lots of other places too to get this information. And one of the ones I like obviously is ISMP, the Medication Safety Alert newsletter that they have. Um, I know Kelly said at the beginning, I did a fellowship with them, so I might be slightly biased. But one of the things I love about the ISMP newsletter is they're short. They describe the problem and give you those actionable items. And like I said, in our articles, you'll see that same type of thing. What's the problem? Here's an example of how it has harmed someone or could harm someone. And these are very specific things that you can do about it. But don't be afraid to take that information and, think bigger or broader. Like I said, maybe you don't have an NICU, maybe you don't use heparin, but do you have overrides? Do you have an automated dispensing cabinet? Like, what are the other things that could be problems? Um, in addition to the medication safety alerts, all of those, there we go. Um, all of the professional organizations, whether it be the emergency nurses or American Hospital Association or any professional organization, they put out practice standards and guidelines, and they put these out not because everything is going really well, but because there's problems somewhere with something. So those can be great ways to kind of look at your processes and figure out maybe where you want to spend some of your time. The American Hospital Association, for example, has really great standards for ECG monitoring in inpatient settings. That's something I know, Kelly, not to steal your thunder, but Kelly's did a lot of work on that, and we have tools and we have a bunch of stuff that goes with that. Um, so you can use all of these different sources to kind of wrap into some of that work that you want to plan to do. And I know that none of you are trying to find work to do. I know we all have lots and lots to do. But this is very much one of those an ounce of prevention is worth a pound of cure type of situations. It's much better to fix the problems before they cause harm than to wait until you have a situation in your facility that has caused harm. And now you're dealing with not only fixing the problem and assessing the risk, because it's a very, very real risk at that point, but you're also dealing with the media and the pressure from leadership and the pressure from staff. And how do we fix this? Um, and other examples too, Joint Commission has things. AHRQ is a great resource. They publish, like their M&M case studies, NQF, IHI, and MPSF, and any other publications. Honestly, like wherever you can get this information from, there are a lot of places that you can go to find it. And if you need suggestions, again, feel free to reach out to us. We're more than happy to help you find problems. We're also more than happy to help you develop solutions to problems as well. Those are the things that we enjoy doing, honestly. So what can media and publications do for you? Again, like take these as opportunities to learn about where potential issues could be in your facility before they become real, honest problems that are going to require a whole different level of intervention. If you can fix them before they harm someone, you're going to be much further ahead of the game. So maybe a little more proactive than some of the other things we've talked about, like chart reviews, where we're saying, go in and try and find where something went wrong. Go and find where things could go wrong before they do. So that's what media and publications do for you. With that, you can go ahead and enter your questions into the Q&A box. Kelly, I will turn it over to you.
All right, thank you, Michelle. That concludes the slide presentation portion of the program. And I see there is one that had come in kind of earlier in the presentation, that is there a national agency that looks at the error across all states as a big picture, or is it a state by state and you just have to hope the national news you watch picks up the story?
Ooh, that's a good one. There is not a mandatory reporting system for events across the country. Um, there are voluntary programs, like for example, ISMP is voluntary. You're not required to report things to them. Um, they only look at medication safety events, though. So there are a handful of national data collection voluntary things. Um, as far as state by state, Pennsylvania is far more comprehensive in the events that we look at here than most other states. There are, I think, Kelly, when we looked last, it was 26 states who had some type of mandatory reporting. Is that right?
Yeah, and I could spend a whole lot of time talking about the independent states and what they do, one versus the other, because in looking at what all the states require, or looking at some of the handfuls that I did investigate, it's so all over the place. We are probably one of the best comprehensive states when it comes to mandatory reporting. So kind of like Michelle's, you're saying, the mandated reporting is not there kind of at that national level, essentially.
And it's about half the states who have, and I would say ours is the most comprehensive. I think most states use some type of a like modified serious reportable event list or something like that, as far as like you have to report these specific types of events. But near misses in particular are not. And there's just not a national repository that exists.
And I know in some of this investigation, I've looked at the PSOs. Some of our organizations within the state of Pennsylvania participate with PSOs. And while they're at a national level, or potentially at a national level, there's so many variations from one organization to the next that there's just not that continuity across those organizations.
And they're still voluntary.
Yep. There is another one. How can I integrate this information and all the stuff that we've discussed into a process with my patient safety committee?
Another good question. There's you could have a standing agenda item on your patient safety committee for, items from the news, or case studies from publications. Different journal articles will publish different case studies based on events, and sometimes you can find things there. You could do it like almost like a journal club, where it could be a subcommittee for that larger patient safety committee, where there's, people who are meeting and talking about these things and identifying some opportunities that then can go back to the larger patient safety committee. But that's a great place to take them, honestly. That's where these discussions should be happening, and really encouraging that open dialogue. I know I have found people are much more open and willing to talk about potential problems when it's not their problem that caused the initial discussion. So sometimes what I mean with that is it's less threatening to take a case like, say, the Redonda Vaught case that people have seen in the news and have heard about, and say, hey, let's talk about how it could happen here. Um, because it's not them who's under the microscope, and it feels like a collective problem solving exercise and not an investigation, or some of the concerns around, like, are we looking for someone to blame? And Kelly, feel free to add anything to that as well.
Yeah, actually, I was thinking about, yeah, and I know you mentioned some of the resources from ISMP. I know an organization used to use at their medication safety committee. They would use those newsletters kind of on a monthly basis when they would have their meetings, and pretty much go down through there and what are those safety alerts that we need to be looking at? What are the interventions that we can be kind of reviewing and analyzing from our organization perspective, what can we improve upon. So it was a great kind of, like you said, kind of putting it on the agenda and using that as a standing meeting agenda item. The other thing I'd mention, I know Michelle had commented early on about when something bad does happen and you have the media. That's one thing we didn't really get into that because, as Michelle had mentioned, it's a little harder to kind of sit back and analyze things without getting caught up in the outcome influencing our decisions. It's much easier to kind of go through some of the reviews if we don't have that actual event here and the media knocking on our door, like who's to blame, what's going on. The redundant scenario and the charges that got filed there, was that a result of pressure from what was going on in the public setting versus what does just culture say? So doing these proactive analyses and reviewing your processes definitely has a great opportunity. Do you have any recommendations on how to engage leadership? It's easy to sit back and say, oh, that's not going to happen here, so why do we have to do anything about this?
A great a great way to engage leadership is show them it can happen here. Um, so when you see those events, like I'll go back to the Quaid example and the heparin. How many heparin events did you have in your facility? Or how many neonatal dosing errors did you have in your facility? Or how many overrides? Because that was consistent with both the automated dispensing cabinet, that the override part was the Radonavot case. Any of those things where you can say, we have this many overrides occurring. This case that was in the news that I'm sure you heard about involved overrides. I think we have an opportunity to shore up our processes here. So it's not necessarily like that they need to be at the table developing those solutions, but making them aware of where the connections between the work that you're trying to do to improve patient safety in your facility and the work that they see you doing, making those connections for them to where the risk really is and where those resources are needed and why it's important can be very helpful.
Thanks, Michelle. That's excellent. Making those connections is important for them to kind of see what needs to be done. I don't know, Michelle, do you have any final comments that you wanted to share?
No, I think I've said it all. Thank you for everyone who participated. We do appreciate your participation. I hope over the course of these 5 webinars, you've gotten some ideas about where you can look to figure out where events are happening that maybe you don't know about, or even events that aren't happening but could happen, and how to improve your processes. Because ultimately, that's why we're here, and that's why you're here, is to all help improve patient safety. So.
Yes, thank you so much. I want to thank everyone again for joining us today. If you experienced any issues accessing the evaluation and/or certificate, please feel free to direct any inquiries to Shelley Meixel at shmixell@pea.gov. This concludes our webinar. Thank you.